Um, Hello guys. So today we're gonna do prolapse, and I want this whole thing down to 45 minutes, wherein we can revise it well and and also take the high yield stuff from it, and this shouldn't be a problem for us again. So let's get started. Our motto: revision makes everything better, and you know what? Let's go with exact quotes. Revision, greatness, quote. So the quote exactly is: the great thing about revision is that it's the opportunity to fake being brilliant. Okay? And like I said, the great thing about revision is it's not an opportunity to fake being brilliant. You're actually working towards being brilliant. So let's get started. What are the things we're going to cover which is needed for the exam? So the things are, let's list it out here. We're going to see the supports of the uterus. Okay, and then we're going to see classification of prolapse, POP, risk factors, degrees, signs and symptoms, investigations, differential diagnosis, and a very extensive management. Okay, all right. Apart from this, we're also going to see, we're going to separately see Fothergill's operation. We're going to see vaginal hysterectomy. We're going to talk about decubitus ulcer. There's going to be a note on pessary, a note on walled prolapse, and two other things: a pessary test and a retroversion of uterus. Okay, so these are things we're going to talk about. So let's get started. The resource I have used is definitely going to be Marrow, maybe some charts from the textbook, and very highly Sharmila here because I've done this topic quite a few times on there, so I felt that was more useful. Uh, so yeah, let's get started. So supports of the uterus. So uterus is not an organ which is like flying in the air. So supports of the uterus will be, we have mechanical supports, ligamentous supports, okay? And then we also have two more things we would like to mention. We have mechanical supports, the ligamentous supports, we have and immediately after this, you're going to mention De Lance's concepts and the biomechanics preventing prolapse. So 4 points we're going to discuss when we're going to talk about supports of the uterus, okay? So here supports of the uterus. So let's get started. So when we write supports of the uterus, four headings. We're going to have the mechanical support. This is going to be uh, angles, and then we're going to talk about three other points, that is constriction, suspension, and flap wall effect. Constriction, suspension, flap wall effect. Second point we're going to talk about is going to be the ligaments which support it, very important. Then we have the muscular support, and fourth very important point, we're going to talk about the De Lance's concepts. Okay, so if you see, we also discuss here perineum, okay, all that. De Lance's support, muscle supporting, and yeah. So this is going to be support. So let's start with uterus is an organ which is supported by, what is prolapse? First of all, prolapse is nothing but herniation of the uterus. Okay, herniation which includes protrusion of a pelvic organ into or out of the vagina, which occurs due to failure of anatomical supports. This is the definition of pelvic organ prolapse. So, herniation of a pelvic organ into or out of the vagina, and the main etiology is the failure of abnormality in the anatomical support. Okay, so this is the definition. Don't miss this out. Then we have supports of the uterus. So the supports of the uterus, like I mentioned, 4 points. What is a mechanical support? So the mechanical support is two things. We have anteversion, anteflexion. How I remember it is FV, right? Flexion is 120, version is 90 degrees. What is the first step in prolapse? Is the retroversion of this angle, this 90-degree angle. So two things. We have the two angles, right? The anteversion, anteflexion of 120 degree and anteversion of 90 degree. Okay. After this, we have the ligaments which support this one, and ligaments form the primary support of the uterus. So the ligaments which support the uterus are very nicely drawn here. We can laterally we have the Mackin rods or the cardinal ligaments, or Mackin rods cardinal ligaments. We have the posteriorly we have the uterosacral ligament. Anteriorly we have the pubocervical ligament. Okay, so these are the these form the triradiate ligaments. Along with this, yeah, this form the triradiate ligaments which support the uterus. 2 points about extra ligaments. Round ligament supports from the angle of the uterus all the way to the labia majora. It maintains the anteversion, but the main ligament in anteversion will be the uterosacral ligament. Okay. Apart from this, we have the broad ligament which does not provide any kind of support. So we finished mechanical support, ligamentous support, now the muscular support. The muscular support is provided by these muscles. So we have 9 muscles which form the perineal body, and we have 3 diaphragms. Okay, so we have the pelvic diaphragm, we have the urogenital diaphragm, pelvic diaphragm, urogenital diaphragm, and then we have the perineal body. So this needs to be revised a couple of times, otherwise you're going to miss out on this. So the pelvic diaphragm is formed by pubococcygeus, iliococcygeus, and not ischiococcygis. Okay, this many muscles done. Fine. After that, we go for we have the levator ani muscle forming the pelvic diaphragm, which has the pubococcygeus, iliococcygeus. Then we have the deep perineal pouch, followed by the perineal membrane. Then we have the superficial perineal pouch, which is formed by the pubococcygeus and deep transverse muscle, along with the superficial transverse muscle. Whereas deep perineal pouch over there was formed by deep transverse perineum and external sphincter muscle. So again, from top to bottom, we have the levator ani muscle, 2 in number, counted. Then we have the perineal membrane, and then we have the deep perineal pouch. No, we have the deep perineal pouch, and then we have the perineal membrane. So deep perineal pouch again, external ureteral sphincter, and then we have the deep transverse perineum muscle. Okay, so deep transverse perineum again paired, so 4 over. Then we go for superficial perineal body, a pouch which has the bubospongiosis, and we have the again paired bubospongiosis, and we have the deep superficial transverse perineum muscle. 6 over, so 3 more left. This will be muscles of external anal sphincter and longitudinal muscle coat of rectum. Okay, so let's repeat all of that. We have superficially we have the perineal diaphragm, which is formed by pelvic diaphragm, which is formed by the levator ani muscle paired. So two muscles over here, and this is iliococcygeus, pubococcygeus. After that, we have the urogenital diaphragm, which is formed by the muscles urogenital diaphragm. We have the deep perineal pouch. The deep perineal pouch is formed from the deep transverse perineal muscle and external urethral sphincter. So this becomes two. Okay, then we have the deep perineal membrane. Then we have the superficial perineal pouch. The superficial perineal pouch is made by the two superficial transverse perineal, deep transverse perineal, and bubococcygeus. Along with this, we have two extra muscles we're just going to name here: longitudinal fibers of rectum, along with fibers of external anal sphincter. Okay, so what and all have we finished? We have finished with the mechanical support, ligamentous support, muscular support. The next one is going to be the De Lance's concept of this De Lance's supports of vagina. So according to De Lance's supports of vagina, we have three levels of vagina, which is supported by three different structures, and the defects and has defects of which have the defects of which have a corresponding issue. Fine. So the upper one third of the vagina is supported anteriorly by the laterally by the sacral ligament and posteriorly by the uterosacral ligament. Okay. Now defect here is going to lead to here backward we can have an enterocele. Anteriorly we can have a and then we can have a central defect wherein we'll have a elongation of the cervix. In the middle one third again we have cardinal ligament. Uh, this is a very important concept. Let's go back and see. Upper one third of the vagina is supported posteriorly by the uterosacral ligament. Anteriorly, let's go anteriorly. Posteriorly by the uterosacral ligament, laterally by the Mackinrod's ligament. Any defect here can lead to 1. Walled prolapse, 2. Enterocele, 3. Uterovaginal prolapse. Okay, so this is what happens in case of level 1. Upper one third of the vagina is affected. Then we go to level 2. Level 2 is middle one third of the vagina, which is supported by arcus tendinous fascia. These are two fascias, which is pubocervical fascia and rectovaginal fascia. Any defect here? Posteriorly, rectocele. Above it is enterocele, rectocele, and anteriorly will have a cystocele. Simple enough? Fine. The third one is going to be a defect in the perineal body and the muscles supporting it. So perineal body, urogenital diaphragm. Any if issue here, anteriorly we have a urethrocoele. Posteriorly we will have a relaxed perineum. We can also have a gaping introitus. So this much must be mentioned when you have support. Okay. So supports of the uterus done. Next question, classification, risk factors and degrees of prolapse. So the classification of uterovaginal prolapse, let's start with risk factors, I think, yeah. So not mentioned here, but I have very extensively written risk factors in prolapse, yes. Just click a picture of it real quick. So we're going to talk about two things, risk factors, classifications, and degrees of prolapse, along with signs and symptoms. Okay, so risk factors, classifications, degrees. Let's just go with classifications and risk factors for now. So the risk factors are, we can have primary, we can have a secondary causes. Okay, primary causes are those which are related to pregnancy, postmenopausal symptoms, and congenital symptoms, whereas secondary is due to acquired causes such as smoking, raised intra-abdominal pressure, such as weightlifting. Okay, I think we have mentioned a few here as well. Yeah, connective tissue disorders that will come under primary. So now in primary, what are the pregnancy, postmenopausal lady, and pregnancy, a postmenopausal lady, and a congenital cause. Okay, so in congenital causes, we can have weak uterosacral ligament because of spina bifida, wherein the blood nerve supply is poor. We can have connective tissue disorders like Marfan's, Ellis-Dollars, and we can have a split pelvis to cause a weak pelvic diaphragm. So these are three causes of congenital. Done. So congenital is over. Then we go for postmenopausal. In postmenopausal, we have just one. That is estrogen deficiency. And estrogen deficiency will cause ataxia and decrease in pelvic floor muscle. Okay. This causes atrophy and decrease in collagen. So we have postmenopausal estrogen deficiency, which causes aesthesia and decrease in pelvic floor muscles, which causes atrophy and decrease in collagen. Last is pregnancy. Now pregnancy extensively let's write here. So in pregnancy, it can be due to first stage, second stage, third stage of labor. In first stage, just to recall, we are doing risk factors and classifications only now. After that, we'll go dwell into the other questions. Okay. You can definitely do it. Come on. In pregnancy, if it is done by an untrained die, if it is a prolonged labor, if it is done in rapid succession, and if there are multiple pregnancies, all of these are risk factors for prolapse. Now, in particular stages, let's go with stage 1, when we can pushing against a closed, incompletely dilated cervix. That's it. Okay. So bearing down, if premature bearing down effect, vacuum before full dilatation, and a big baby or prolonged labor. These are for stage 1. Stage 2 is simply perineal injury, okay, which is very important because it can be prevented with timely episiotomy. Stage 3. It's similar to stage 1 where we vigorously push for expulsion of placenta by applying fundal pressure. This is nothing but Crete's method. Okay, so these are the causes for uh, pregnancy related prolapse. The last one will be primary. What did we finish? Primary, yeah, secondary. Secondary is because of acquired causes like chronic smoking, increased intra-abdominal pressure, as in case of ascites, constipation, uh, abdominal tumors, and weightlifting. So I think this is good enough for risk factors for prolapse. Next, we come to classification of prolapse. I think I have a nice image of that as well. Okay. Uh, Next heading, classification of girls. Let's see how much time we have left. We have classification, a few more. I think the time will go in mostly vaginal hysterectomy and some steps. How long have we been recording? 20 minutes, halfway through, and so much more to do. Let's go. So, classification of prolapse will be again, what is a prolapse? Pelvic organ prolapse is herniation of organ from into or out of the vagina due to abnormality in the anatomical support. Classification is first listing out. Shaw's classification. We have the POP, pelvic organ prolapse classification. We have the MAPLAS etiological classification. We have the Baden-Walker halfway classification. We have the Jeff Coates introitus classification. Yeah, that's it. Five classifications. So according to Shaw's classification, listen, a easy way to remember is just remember what mainly they're trying to say so that you could like go about with the rest. So we have Shaw's classification. What Shaw used was ischial spine. Okay. So according to Shaw, so in the classification we have Shaw's classification. Shaw's classification simply is with respect to ischial spine and introitus. Okay, introitus is nothing but internal os. So he had 4 degrees. Let's go. This is the ischial spine. This is the introitus. So first degree, it is below the introitus, but it's below the ischial spine, but above the introitus. First degree. Second degree, up till the introitus, but not beyond the introitus, and below the ischial spine. Third degree, out of the introitus. Fourth degree, complete inversion, that is procedentia. So Shaw's classification of the prolapse of grading of uterine descent. Along with this, he also commented on anterior vaginal wall and posterior vaginal wall. So, anterior vaginal wall, upper two-third, it was related to bladder, so cystocele, lower one-third urethrocoele, posteriorly upper one-third enterocele, rectocele, lax perineum. Okay. So this is the Shaw's classification. Next classification is POP classification.